Cataract refractive surgery is a frequently used term that refers to lens replacement procedures in which a refractive correction is also performed. But when it comes to discussing charges and billing with your patients, have you considered whether this commonly used term might be doing more harm than good? It could sound like there are different kinds of cataract surgery and you're offering the refractive kind. In other words, it can sound like one service instead of two. Surgeons and people in the IOL industry know what cataract refractive surgery means, but when speaking to patients, cataract surgery and refractive correction should be presented as two separate services. Today we're going to walk through some hypothetical surgical scenarios and suggest how you might apply the two-service concept with patients who choose advanced technology IOLs, also known as AT-IOLs. We'll start with an analogy in the cosmetic surgery world. Meet Rufus. Rufus is a speed demon, but he doesn't always ride safely. And he ends up with a broken cheekbone. Rufus needs his broken cheekbone repaired after his accident, so he goes to see Dr. Cutsit, a plastic surgeon. Dr. Cutsit tells Rufus that he can repair his injured cheekbone. It's a routine service performed in an operating room at a hospital or surgery center. Rufus has an idea. He has always hated his nose, so he thinks this would be a good time to have a nose job too. Dr. Cutsit understands Rufus's desire to cosmetically change his nose. He explains to Rufus how both the nose job and the cheekbone repair can be done on the same day. He considers calling it nasocheekial enhancement, but then realizes that using a single term for two separate services could confuse Rufus's understanding of his medical bills. He realizes that Rufus needs to understand that two separate services will take place, even though it will seem like one surgical event to Rufus. Dr. Cutsit doesn't describe it as nasocheekial enhancement surgery, even though that's how he and other surgeons commonly refer to it. To prevent billing complaints later, Rufus needs to understand now that these are two separate services, cosmetic rhinoplasty and cheekbone repair. Since his cheekbone repair is medically necessary, it will be covered by insurance. But the rhinoplasty is cosmetic, so Rufus will need to pay for this service in its entirety. Dr. Cutsit explains to Rufus that he will be charged a copay for the surgeon's work to repair the cheekbone, and he'll also be charged a copay by the ASC for the cheekbone repair. He also explains that, in addition to the two copays for cheekbone repair, Rufus will be billed a professional fee from Dr. Cutsit and a facility fee from the ASC for his cosmetic rhinoplasty. This is because it is a non-covered service. Two bills for each of the two services means 4 separate bills for Rufus. Rufus likes Dr. Cutsit and how clearly he described the billing for the two services. He decides to go ahead with both. And he also promises to wear a full helmet from now on. Now, let's apply this approach to explaining AT-IOL services to cataract patients. Rather than just emphasizing the differences between AT-IOLs and conventional IOLs, it's wise to inform patients that two services are being provided and one is not covered by insurance. Dr. Getsit, an ophthalmologist, has just diagnosed Mr. Barton with bilateral cataracts. Mr. Barton doesn't know much about cataracts and wants to know if he'll still need his reading glasses after cataract surgery. Dr. Getsit explains that Mr. Barton wears reading glasses because of an eye disorder known as presbyopia, not because of his cataracts. She then shares the good news that he has options. He can just have cataract surgery, which Medicare covers, or he can have cataract surgery plus an additional service to correct the presbyopia. Dr. Getsit explains that correcting presbyopia is not medically necessary, so Medicare does not cover it. If Mr. Barton wants presbyopia correction done while he's in the OR for cataract surgery, then he will be responsible for the additional charges. Additional charges account for the components associated with presbyopia or astigmatism correction that aren't medically necessary for cataract surgery. This includes additional diagnostic testing and supplementary imaging required for correcting presbyopia or astigmatism. Dr. Getzit reminds Mr. Barton that he will receive bills from both the surgeon and the ASC. Each of them will send 2 bills. One for the cataract surgery copay, and another for the professional or facility fees for presbyopia correction. Now, when Mr. Barton receives his bills in the mail, he will understand why he is receiving 2 separate bills and will appreciate Dr. Getzit taking the time to thoroughly explain the billing process. Now that you are well versed in how to help patients understand multiple services in one operative session, there are a few other important things to remember. When explaining your charges for cataract surgery with an ATIOL, do not use the phrase balance billing. Balance billing means charging the difference between your charge and the insurance payment for a service that is covered by the patient's insurer. CMS and virtually all private payers do not permit balance billing for conventional cataract surgery or lens replacement with ATIOLs. Instead, they acknowledge that when ATIOLs are implanted during cataract surgery, 2 separate services are being provided. The cataract service is covered, and the other service, presbyopia correction or astigmatism correction, is not covered. So how do you stay within CMS guidelines? Let's review it from the surgeon's perspective and note the facility implications along the way. If, for example, the surgeon charges $1,500 for cataract surgery, but Medicare only pays $775 for cataract surgery, then the surgeon's bill for cataract surgery would look something like this. Start with the surgeon's fee for cataract surgery, subtract the Medicare payment, and then the remaining balance is written off. Although the dollar amounts would probably be different, this billing structure also applies to the facility's bill to the patient. Then, in a separate line item, or as a completely separate bill, the surgeon would bill the patient for physician professional services such as diagnostic tests related to the correction of presbyopia. The surgeon's bill is assumed to be $3,000 in this illustration. On the other hand, the facility's bill would reflect the higher cost of the ATIOL relative to a conventional IOL, including the facility's standard markup on that incremental cost. So, using those assumptions regarding charge amounts, the surgeon's combined revenue for cataract surgery and presbyopia correction is $3,775. The same principles apply to charges and revenue associated with astigmatism correcting IOLs. It's that easy. Patients may better understand the billing of cataract surgery with an ATIOL if you properly present the surgical event as 2 services, one that's covered and one that's not covered. Viewing it this way will also help you determine what items and surgical steps can or cannot be charged to patients who choose an ATIOL. Surgeons often question whether a certain item or surgical step in cataract surgery with an ATIOL can be billed to the patient. To answer the question, ask yourself, does this item or step belong to cataract surgery, presbyopia correction, or astigmatism correction? If you routinely use a particular device, drug, or surgical step during lens replacement with conventional IOLs, then CMS regards it as part of your cataract service, and it cannot be charged to the patient. When an additional non-covered service is performed, such as presbyopia or astigmatism correction, then patients may be charged for additional work and steps related solely to that service. To answer the question of whether the patient can be charged, ask yourself, to which service does the item or step belong? If it's a step that you do to correct presbyopia or astigmatism with an AT-IOL, but that you don't typically perform for conventional IOL cataract surgery, then you may include it in your charges for presbyopia or astigmatism correction with an AT-IOL. Examples include preoperative corneal topography, the extra cost of the presbyopia correcting or astigmatism correcting feature of an AT-IOL, imaging specifically for a highly precise placement required for an AT-IOL, and the functionality of the Varian image-guided system that is specifically for AT-IOLs and not used for conventional IOLs. If a service or step is also done for lens replacement with a conventional IOL, such as fragmenting the nucleus or performing a capsulotomy, then it's part of cataract surgery, and you should not charge an AT-IOL patient for it. Guidance released by CMS in 2012 acknowledges the imaging function of a femtosecond laser as an example of a step that surgeons may perform in conjunction with the non-covered aspect of an AT-IOL. The guidance also allows that limited, non-routine use of imaging in cataract surgery with a conventional IOL does not prevent imaging from being chargeable to AT-IOL patients. If a particular provider routinely uses imaging for conventional IOL services, then imaging is regarded as a part of that provider's cataract surgery technique. That provider may therefore not include imaging in his or her charges to AT-IOL patients. Arcuate cuts and associated imaging when done with a femtosecond laser are not steps of cataract surgery with a conventional IOL. The arcuate cut is part of a separate non-covered service, so imaging for an arcuate cut does not count as a step being routinely used for cataract surgery. As long as you don't use imaging routinely in cataract surgery with conventional IOLs, then you can continue to include it in your charges for these non-covered services. Common non-covered services include presbyopia correction with an AT-IOL, astigmatism correction with an AT-IOL, and non-covered services involving arcuate cuts. Now you get it! Please contact Alcon Reimbursement Services or your Alcon Surgical Sales Representative for more information.